Well, there certainly are numerous developments in the area of VTE prevention, really focused in on the inpatient to outpatient transition. And I think what we have started to appreciate is not only is there a significant VTE burden in the hospital, but we're beginning to realize that once patients leave the hospital, they face a significant risk for VTE. In fact, we know from the evidence that approximately 2/3 of all VTE occur after a patient leaves the hospital in the first 90 days occurs in the first 30 days. So the first 30 days is a nice opportunity to think about risks of VTE once patients leave the hospital. So the newest developments really center around the most recent data from the MAGELLAN study, looking at the extension of prophylaxis for patients who start in the hospital and who leave the hospital and continue on prophylaxis for approximately 35 days. I'd have to say that that's certainly a paradigm shift, thinking about inpatient to outpatient. And also I'll mention, of course, as we think about rivaroxaban, this is an oral therapy. And so for the first time, as we think about prophylaxis, we are no longer talking about the subcutaneous prophylaxis, but we're thinking about an oral treatment. So I think that's exciting in this whole area. There are regulatory changes. And as we think about regulatory changes, of course, we think about the Joint Commission and we think about reporting data from hospital care. And as we know, often reporting of data gets converted into payment incentives. So as we think about VTE, there are 6 VTE metrics that were initially identified by the Joint Commission. And now those metrics have now been narrowed down to VTE1 and VTE2 metrics, which relate to the use of prophylaxis for the medical patient population who is admitted to the hospital and medical prophylaxis for patients who are admitted to the intensive care unit. So within the reporting requirement, there's the hospital inpatient quality reporting program. And that program allows hospitals to choose 4 clinical metrics to report within this program for an incentive-based payment in 2023. Currently, they're at the reporting stage. And so what this really highlights is the fact that within the regulatory environment, the Joint Commission values the importance of the concept of prophylaxis for all of our inpatients in internal medicine, as well as the intensive care unit, and the subsequent documentation of a contraindication, if there is one, for prophylaxis, and to initiate prophylaxis for all of our inpatients. And so I see that as an important regulatory metric, and that has been a recent change within the VTE environment. Now, I will add that rivaroxaban has recently been added to the VTE1 and VTE2 metric as a acceptable prophylaxis alternative to low molecular weight therapy, which had been the standard of care in the past. And so some of this relates to the initial study that I mentioned earlier, the MAGELLAN study, which of course I'd be happy to answer questions about. The MAGELLAN study, as well as a sub-study of MAGELLAN, was recently published in the literature. And now there is an FDA approval for the use of rivaroxaban for prophylaxis for our medical inpatients to then continue up to day 35, even when they leave the hospital. So the study looked at the current standard of care, which was enoxaparin, and it compared it to a 10 milligram dose of rivaroxaban, started on the day of admission and continued up to 35 days, even after a patient left the hospital. The inclusion criteria included patients with cardiac disease, pulmonary disease, infectious or inflammatory disease, as well as ischemic stroke. So if a patient had one of those medical conditions, they were randomized to either low molecular weight heparin or 10 milligrams of rivaroxaban. At the conclusion of the 35 days of the study period, there was a 32% relative risk reduction in VTE as defined in the study for the rivaroxaban arm relative to the low molecular weight heparin arm. And the major bleeding rate was 0.7% versus 0.5%. So very close in major bleeding and a 32% relative risk reduction in the incidence of VTE. Now, I'll remind everyone that patients did need an additional risk factor, such as age over 75, elevated BMI, prior VTE cancer or some thrombophilia or thrombophilic condition. So if they met that criteria, we have now an oral FDA-approved option for VTE prophylaxis that can be started when patients are admitted to our hospitals and then continued up to 35 days even after they leave the hospital for a 32% relative risk reduction in VTE.